Support for your public radio station comes from our members and from the Golisano Foundation, supporting Move to Include programming on WXXI and working with the community to lead change toward the inclusion of people with intellectual and physical disabilities. Share your thoughts at movetoinclude.org.
From WXXI News, this is Connections. I'm Evan Dawson. Our connection this hour was made at 10:24 in the evening when a man in his 40s began having a stroke. As a man in his 40s myself, I don't often think about stroke affecting people that age, but I'm 47 and my dad was 47 when he had a stroke. And, we all have to think about what we would do. Well, Joshua Graves knew that something was wrong, and his daughter called 911. 15 minutes later, the UR mobile stroke unit was at his door. Today, Graves says those 15 minutes saved his life. He offered to be part of a new video for social media describing his experience and why he credits the mobile unit for not only his life, but for preventing devastating effects that can come with stroke. URMC's mobile stroke unit is equipped to deal with the effects of stroke on site or in transit to a hospital. So instead of waiting to get to a hospital for evaluation, teams can begin treating immediately. This hour, a conversation about what to do in an emergency and how this unit is designed to make a difference. And our guests include the man we were just talking about. Josh Graves is with us. I'm so glad to say a stroke survivor. It's nice to see you. Thank you for being here, Josh.
Thanks, Evan.
With us in studio, Dr. Adam Kelly is professor of neurology at the University of Rochester Medicine Comprehensive Stroke Center, associate chair of teleneurology and regional programs, and director of the University of Rochester Medicine Telestroke program. Doctor, welcome. Thanks for being here.
Thank you.
And Dr. Tarun Bala is professor of neurosurgery at the University of Rochester Medicine Comprehensive Stroke Center. Doctor, welcome to you as well.
Thank you.
We're going to get Josh's story in just a moment, but this is an important day. In fact, going right across the street at 1 o'clock, guys, for what's going on there. Well, I'll start with Dr. Kelly. What's happening today?
Well, we have a press event that is celebrating the launch of our second mobile stroke unit. Our first unit started in 2018, and it's been very successful, and we realized it was time for a second unit to upgrade and just make sure that we have better coverage with this unit as much of the time as possible.
Well, and Dr. Bala, as a professor of neurosurgery, I presume that means part of your work is surgical intervention for people who are in emergency. Is that fair?
That's correct.
Do you do it on in the unit, or are you on site at the hospital?
No, not in the unit. We're not quite there yet.
Okay.
On site at the hospital.
Yeah, but how important is that unit to you, given the work that you may have to do in an emergency that seems, by the minute, which we'll talk about, to get worse as time passes?
Yeah, it's priceless. I think in a time-sensitive disease process, in order to be able to get the patients to the right hospital at the right time, after even delivering immediate care at the scene, time is brain.
Dr. Kelly, where is your work typically happening?
Well, I work at Strong, I work at Highland, but then I do have a big presence with our Telestroke program.
Yep.
And basically the concept there is we bring the physician, we bring the specialist to the location where the patient is. And increasingly these days, that is the mobile stroke unit. So even earlier today, I was covering the mobile stroke unit, and the team there, if they bring on someone like Mr. Graves and he needs to be evaluated, we connect by video.
Yeah, I was going to ask you how often the mobile unit is needed now.
It really varies. We're called a lot by 911. We're dispatched by 911 to evaluate a potential patient. We are sometimes called by an ambulance crew who arrives on scene for a patient that maybe wasn't initially dispatched as a stroke, but the team gets there and realizes they need the assistance of the mobile stroke unit. So we're dispatched several times a day. We probably bring, maybe one patient a day onto the unit. We're quite selective because it's a very limited resource, and we want to make sure that we bring patients on, like Mr. Graves, who are going to really benefit from the care that we can provide on that unit.
Later in the hour, we'll answer questions from the audience about stroke. I'm going to ask the doctors coming up here to tell us about the differences between ischemic, hemorrhagic, and TIA, and how to recognize that. I had a family member years ago who sort of glibly said at dinner one day, well, I think I have several TIAs a year, as if she's sort of self-diagnosing. And I thought, maybe talk to a doctor first. But it is remarkable. I mean, I had an next door neighbor, as I mentioned right at the top of the hour here, that he was gone for a few days. This is about 5 years ago. He was gone for a few days, came back, and he said, yeah, I woke up in the middle of the night and told my wife I thought I was having a stroke, and I was. But not everybody can self-diagnose in that moment, right? I mean, to state the obvious.
Correct. And so part of our education really these days is educating patients about stroke warning signs, but really educating families. One of the big things that we're trying to do is get out and educate in schools so that, children like we're going to hear about here, who recognize stroke symptoms in their parents, their grandparents, other people can activate 911.
And Dr. Bala, my father had a stroke, collapsed playing paddle one day when he was 47 years old. And, I was a kid at the time, and to me, 47 was old. I had this image in my head of, well, only older people get strokes. Well, now that I am 47, that does not feel old. And is there a typical age curve, especially when they get to you for operation? Does it skew older, or do you see a range of ages?
Yeah, I mean, stroke is definitely a disease that tends to skew in a little bit of the elderly. But it is a disease that doesn't discriminate. It doesn't mean that young people aren't afflicted. The causes are different. And that's where the important thing is in trying to manage some of the risk factors as we age.
So let's get Josh's story here. This is going back, 4 or 5 months now? How long ago? January. And pull that mic up right for me there, brother. There you go. Yeah. In January. So take me through the day if you could. I'm going to let you kind of tell the story a bit, and then we'll kind of get into some of the specifics. But walk us through what happened the day that you had your stroke.
I was having a weekend with my daughter. We were doing a little bit of side work, and it was a normal Saturday. I was in the process of doing some of the window replacement that was for a friend, and my daughter noticed that I wasn't speaking correctly, that my motor function started to kind of fall off. I to be honest with you, I never noticed any of it.
Okay.
It never even registered. To be honest, I actually disputed with her that it was that way. I'm fine.
She noticed, and she actually said something to you.
Absolutely. Yes.
And you said, nah.
I tried to dismiss it.
Okay.
And then basically just lay down, Dad, sit down, and I did. And as soon as I did, immediately started losing sensation, feeling, and the ability to move the left side of my body. My face started to droop on the left side. She jumped right into action. She called 911, said something's wrong. My dad's probably having a stroke, something, and you need to get here fast. AMR or the people at Penfield Ambulatory came right down the street. They were there very quick. They immediately identified it as what it was, which is a stroke, and they called the mobile stroke unit in from Strong. They arrived not long after. We were changed over at the Penfield Ambulatory, and then they jumped into immediate action. They called, and you guys will have to please correct me, TKN, is that?
TNK.
TNK, okay. That was a necessary action to be done. And from what I understand, it has to be called in, it has to be verified.
What is TNK?
TNK is a clot breaking medicine that we can give within the first few hours after someone is experiencing stroke symptoms.
Okay.
And Evan, without any hesitation, they did everything they could, and if it hadn't have happened as quick as it did, I would not be in the condition I'm at now, which is pretty remarkable.
So, you look good. You sound good. We'll get back to that day, but how do you feel today? And how do you feel most days now?
If I had to put a percentage on it, I'm 85, 90%. I don't have any physical or motor function, layover from what happened. A lot of it's mental. My memory wasn't great to begin with. It's a lot worse now. But any longer, me not getting some care would have made the outcome a lot worse.
Can you say a word about your daughter and how remarkable she was?
Without getting emotional, absolutely. I wouldn't be here if it wasn't for her. I couldn't be more proud. She's a great student. She's an excellent athlete. She's going to Spencerport Middle School, going to the high school next year. It's not something that she'd ever been privy to. We didn't prep her for these kind of things, so that was all just her natural instinct.
And how old is she?
She's 13. 13 going on 30. You know what I mean?
Yeah, that is the definition, man. That's amazing.
Yeah.
What a kid.
She just last week received a Do the Right Thing award from the county, and absolutely just a proud parent. And she absolutely knows what she did. She's very sorry, this is one of those things humble. She's very humble, so she doesn't like the spotlight either, but she knows what she did for me.
How aware, once things really got going, how aware were you of what was going on around you?
I was in the moment all the time.
Okay.
I think it really hit me when I literally couldn't move my left leg or my left arm. I couldn't feel touch. Zach and the guys that were in the unit, were routinely asking questions, trying to, get the information out of me that they needed. I was cognizant, I was aware, but I felt helpless.
Okay, so let's kind of check in with the doctors as we go throughout this story. So, first of all, his daughter notices, guys, that something is up with his speech, right? Is your speech? Mm-hmm. And is that aphasia? I mean, is that the word? Is that the wrong word? Is that the right word?
Yeah, aphasia is really dependent on what side of the brain is having a stroke. If there's something wrong with your speech, it could be the inability to actually form the words, or a weakness in the muscles that are trying to sound the words out. So I suspect what you probably experienced was something called dysarthria rather than true aphasia.
Okay. And how common is some kind of speech interruption in stroke?
It's quite common. It's one of the hallmark symptoms that we tell people to look out for. We have a mnemonic called B FAST, which, B is balance, E is eyes, F is face, A is arms, S is speech. So it is one of the, the classic symptoms that we have people, on the ready to look out for. There are other things that can cause slurred speech. So it's not saying that every situation with slurred speech is indicative of a stroke, but certainly slurred speech plus a facial droop plus starting to have difficulty on the left side, that is a stroke until proven otherwise.
Years ago when I was a reporter in local television news, there was a lot of emphasis when a reporter in Los Angeles had a bout of what I thought was aphasia on the air, and it was it was like 30 seconds long. She was trying to say words, and it was not words coming out of her mouth. A lot of people called that station in LA asking if she was having a stroke on the air. I don't have all that in front of me, but I don't think that's necessarily a stroke, though, right? I mean, the point being that there may be sort of some crossed up indicators that could be different things. Is that right with speech in a moment like that?
Sure. There are stroke mimics, things that in the moment can resemble a stroke, things like migraines, seizures. I think the case that you're talking about, I think ultimately was concluded that this was some sort of atypical manifestation of migraine, but those are things that would be considered diagnoses of exclusion. We've got to rule out a stroke or some other brain problem causing that before we make a judgment that this is not a stroke related problem. I'm a pretty regular migraine sufferer. I mean, I say sufferer. They used to be much worse in terms of their intensity, but multiple times a year. And there have been times where I have not been able to fully form words just for a brief amount of time when aura is really heavy and I feel pretty dissociative. And my mother one time said to me, are migraines like mini strokes? I don't think that's correct. Can we clear that up there, guys?
Correct.
Okay. So a migraine is not a mini stroke.
That is correct.
Okay. But what was going on with Josh was indeed a stroke. And as you were cognizant of what was going on, were you still unable to speak and communicate at that point?
There were specific questions asked that I was able to answer.
Okay.
But anything, I guess that was trying to think of exactly how to word it. But
let me help you with the question.
Sure.
Were you able to answer yes or no questions?
Correct.
Okay. Were you able to speak at length about what was going on with you specifically? No.
Not the way that I can normally.
Right. Okay. So, but you never lose consciousness throughout this. Is that right?
Negative. No.
So you're kind of aware of everything that's going on here. What else were you aware of that was happening in the unit on the way to? You ended up going to the hospital, right?
Absolutely.
Yeah.
Immediately. I could definitely tell that we were in motion. I could definitely tell that, IVs were put in. There was conversations with the hospital staff going on with the people in the truck at the time. It's basically like a functioning emergency room in the back of a vehicle.
Mm-hmm.
I mean, there's no other way to say it. But everything that happened in there made it possible for more information to be given when we were at the hospital. They were prepared. They knew what was happening. It's not like I just showed up and they're, what do we do with them? That kind of, it felt controlled. It felt like I was in the right place, 100%. That the right people were there. It wasn't just somebody who was an EMS tech. It was somebody who was specialized in what was going on with me at that moment.
Amazing stuff. So let's ask the doctors. I mean, can you get a better review for what you're all doing there? That is pretty amazing stuff, isn't it?
That is a pretty humbling experience to hear. And you're absolutely right. The whole purpose of the entire staff on that mobile stroke unit, I mean, they are the special forces of stroke in Rochester, New York. Their only job is to treat stroke, and they are exceedingly good at it.
So let me ask an ignorant question then that's related to that, but sort of before the mobile stroke unit days, if someone is going through what someone like Josh or other patients are going through, and they end up needing your services in surgery, how important or how valuable is it for them to arrive on the premises at the hospital and the team already is aware of a game plan versus how much time it would take to kind of go through a diagnosis or a determination of what to do?
Yeah, it's all about time. All right. The quicker we know, the quicker we can get the operating room prepared, the quicker we can get the anesthesiologist prepared. We have our teams coming in. We have everything we need open and ready to go. And right now, our workflow is such that if a patient comes in with a mobile stroke unit and needs to go to the operating room, they're barely even stopping in the emergency room. They come right in, they get a wristband put on there, and they go straight down to the operating room because all that communication has happened.
Yeah. Anything you want to add to that part there, Doctor?
Yeah, I think what we've really done is, and Josh mentioned this, we have essentially an extension of the emergency department in the mobile stroke unit. So in his case, it's not just getting information, which we will then use when someone arrives in the hospital. We are delivering this TNK, this clot-breaking medicine, on the scene. So we are, the concept of time is brain, we are meeting the patient where they are. We're not waiting to bring them in and then delivering care there. We are delivering care, sometimes within a few minutes of arriving on the scene. And so really to give this clot-breaking medicine, we need to understand whether the person is having symptoms that are worrisome for a stroke, and then we need to do a CT scan to make sure that this is an ischemic and not a hemorrhagic stroke, and then we are delivering that medicine as quickly as possible. And the team that we have on the unit is outstanding. Like I said earlier, one of my partners or myself, we will remote in by video so we can see everything that's going on. We look at the CT scan as it's coming across, and we really have everything between the critical care nurse, the CT technician, the paramedic, the neurologist is joining by video. Everyone has their role. Everyone works together, and we can deliver care extremely quickly and hopefully have outcomes like we have here.
Doctors, Josh described your left side not being able to feel it and use it, right?
Correct.
Okay. Including your face?
I couldn't feel the face,
Okay.
but trust me, everybody let me know that was happening.
Okay. Why the left side? Is it typically the left side?
No, it could be either. It depends on which blood vessel is blocked on which side of the brain.
Okay.
In Josh's case here, it was a blood vessel on the right side of your brain that was affected. That was stopping blood flow from going to an area of the brain that brought about all your symptoms.
Mm-hmm.
Okay. And how common is that symptom during stroke, a numbness or an inability to use part of the body.
Very common.
Is it every time?
Not every time. There is variation, but that is one of the more common syndromes.
Okay. Can you tell us about sort of the rest of the experience and put a bow on it?
One of the things that I actually appreciated the most is you guys have all that information. It goes directly into your MyChart. So as a person with a cell phone and waiting for whatever in my room or in the emergency, I could also see those pictures. And to answer a question you asked earlier, Evan, the point where I felt I understood the gravity of what was happening was being able to see the white spot, that had been created from the lack of blood flow in my brain, and understanding that if the actions hadn't happened the way they did, it would be much bigger.
Being able to see
the basically the way it comes up on a CT scan, and you guys can answer this more than I can, but it's a white spot, and that white spot is unusable brain for the rest of my life. You know what I mean? That's part of where some of my speech problems or some of my memory recall comes from, issues with that. It would have only created a bigger spot on that scan. That's the thing I understand.
How's he doing with that, Dr.
Yeah, I think he's doing quite well. I'll just fill in a few simple details. So what Josh is referencing is certain pictures on his MRI scan, which specifically look at areas of the brain that have been recently affected by a stroke. And so we could see that there were some small areas of the brain that were injured, again, on the right side of the brain, corresponding with the symptoms that he had. But really a much smaller territory of brain than we suspect would have been damaged had he not gotten that clot-breaking medicine. And to take things just one step further, when he first came to Strong, after getting the clot-breaking medicine, we did a CAT scan of the blood vessels leading to the brain, and we could see that there was a branch on the right side that was still partially blocked off. And then by the following day, we repeated that CAT scan of the blood vessels, and that blood clot was completely gone. So that medicine did really precisely what we expect. I would love to say that we could give that medicine and all of that white spot that represents areas of the brain that was damaged would go away. But realistically, the brain is so sensitive to lack of blood flow, even a few minutes of no blood flow can result in some injury. But again, we're confident that medicine did a remarkable job at decreasing the effects.
If he had been an hour later, is there a way to know how much worse it would be for him?
Yeah, so generally speaking, we like to say in our field that during a stroke, you lose about 2 million brain cells a minute. Right. So
I don't know how many brain cells we got.
Yeah.
And is that a lot? It sounds like a lot.
Well, I think some brain cells are more important than others.
Okay, yeah.
Right.
Yeah.
So it depends where you're losing them. But for any one of us, we can't afford to lose even one, I would say. And 2 million a minute, 30 minutes, that's a lot of brain real estate that's at risk. And that's the thing about the brain is once it's damaged, we can't reverse that damage. Nothing we can do will bring that function back. So the best thing is to intervene early and to make a difference early. And that's what the mobile stroke unit's designed to do.
So I have a couple of questions from the audience here. Michael in Fairport says, what procedures can be done on the mobile unit that can't be done on a typical ambulance?
So the mobile stroke unit is equipped with a CAT scan. And if you think about other time-sensitive diseases, so things like a heart attack, for example. Now, during a heart attack, it's painful. Patients will clutch their chests. We actually have something at most ambulances and most emergency rooms that can measure the electrical activity of a heart, an EKG, a very basic test that we can do that can tell us if somebody's having a heart attack, or is it just real chest pain. Now, during a stroke, there's no pain. I didn't hear Josh describe pain at all. And we
no pain?
Not at all.
Okay.
We really rely on the neurologic exam and the CAT scan to determine whether or not somebody qualifies for this clot-busting medication. So that CAT scan is a key piece of information for that patient and the neurologist to make that decision. Most ambulances don't have CAT scanners inside them.
Okay.
We can also do every lab that the emergency room can do for making those decisions. So as we were putting in IVs, your blood was being drawn, and there's all this equipment on the mobile stroke unit that we can get all your blood work and stuff processed. There are medications that we use in our intensive care units that are stocked on the mobile stroke unit that can be used if needed. So it really is an emergency room, or what we refer to as a primary stroke center on wheels.
Michael, I hope that answers the question there. And let's get, Tom says, my wife is a 2-time stroke survivor. Clots caused by a hole in her heart. He says, my EMT training saved her life, and that both times I realized she was having a stroke, but she did not. Sounds like Josh's daughter. Each stroke, he says, was caught quickly, and she has suffered no severe after effects. Time. It's how quickly you can recognize. So Tom's story there and his wife, yeah.
Yeah, I think, Josh, giving his story, our listener giving his story, I hope people, if they take one thing away from today's session, is that you cannot wait to get help. If you or someone else might be experiencing a stroke, we see way too many times where someone says, let me, quote unquote, try to sleep this off, or let me try to go to urgent care, or let me, go to my primary care doctor's office. If you are having stroke symptoms, this is, do not pass go, do not collect $200, pick up your phone, call 911. Because, if not, then, our options are going to be limited and the outcome may not be as good with any delays.
I get the point about primary care or waiting till the next day. But a lot of people, maybe me included, hear the words urgent care and think, well, that's where you should go. You're indicating that in this case, that's a mistake.
I think if you go to urgent care, they're going to turn around and say, you have to go to emergency department. Urgent cares do not have CT scanners. And, as we've kind of learned from Josh's story, and we've talked about, one of the first forks in the road for stroke care is we need to figure out if this is a hemorrhagic or bleeding stroke or a non-bleeding stroke. And short of a CAT scan, there's really no way to do that effectively at the bedside.
Okay, so ischemic is a blockage. Is that right?
Yeah,
that's correct. That's most strokes?
That is the majority of strokes. In fact, about 70% of strokes would probably fall under that category.
And that was Josh?
That was Josh.
Which is why you used I forgot the letters.
TNK.
TNK. And so hemorrhagic, something is bleeding.
Yeah, hemorrhagic means that a blood vessel has ruptured and leaked blood into the substance of the brain, and the brain has been damaged as a result of that blood being leaked.
We'll talk more about TIA, which is transient ischemic attack, in our second half hour, because I already have emails about this from listeners that we'll get to. But just when it comes to ischemic and hemorrhagic, is hemorrhagic typically more devastating, or is that not correct?
I think both strokes can be devastating in their own ways.
Certainly.
We have the ability to treat ischemic strokes better than we do to treat hemorrhagic strokes, because the bleeding can happen in various places in the brain. It can happen with various sources, and the degree of bleeding that goes into the brain can be quite devastating.
This is where, all these years later, when my dad was 47, I don't remember. What I remember as a kid in 7th grade was being told that he had a stroke. I thought at the time I was told he had an aneurysm or something ruptured. That sounds hemorrhagic to me.
That is hemorrhagic. Yeah.
Okay.
Yeah, it's a different kind of stroke, but it does fall under the hemorrhagic.
Okay. I mean, they must have done a great job, because he's 81 and doing fine, and didn't lose a whole lot of motor function or other things. But that's why we're talking to the experts this hour, because time is quality of life with a stroke. And after we take this only break, we're going to come back. Josh is doing a great job telling his story this hour. Josh Graves doing better than I thought he would. I joke because I know him a little bit outside this, and I actually think he looks better after his stroke. You look great, man.
Thank you, brother.
It's great to have Josh. We are so proud, by the way, of Josh's daughter, who I wish was here, but I'm sure she's listening or will listen, and she should know that everyone is saluting her work and recognizing her dad's stroke when her dad did not, and making that call, getting that mobile unit. This mobile unit now is doing the kind of work of both saving lives and saving quality of life. And Dr. Adam Kelly and Dr. Tarun Bala are here talking about what happens during stroke and what we should know. So we'll take more of your questions. I should mention, by the way, it's 844-295-TALK if you want to call the program toll-free, 844-295-8255. 263-WXXI if you called from Rochester, 263-9994. You can join the chat if you're watching on WXXI News YouTube channel. And if you want to email, as always, connections@wxxi.org.
Support for your public radio station comes from our members and from Excellus Blue Cross Blue Shield, providing members with options for in-person and virtual care, creating ways to connect to care when and where it's needed. Learn more at excellusbcbs.com. And Bob Johnson Auto Group, believing an informed public makes for a stronger community. Proud supporter of Connections with Evan Dawson, focused on the news, issues, and trends that shape the lives of listeners in the Rochester and Finger Lakes regions. BobJohnsonAutoGroup.com.
This is Connections. I'm Evan Dawson. I want to just mention something that the doctors mentioned during our brief break here. This is important. And this is not me doing PR for medical systems. This is reality. I mentioned that my next door neighbor years ago had a stroke and was gone for a few days, came home, he's doing really well now. Woke up in the middle of the night, talked to his wife, said, I think I'm having a stroke. She took him to the emergency room. He did not go in a mobile stroke unit. And obviously what UR Medicine is doing with a mobile stroke unit is remarkable, and it can save lives. But I think the doctors want to make a point here that whether you're in Monroe County or in a different place served by UR Medicine or wherever you are, if you can't get a mobile stroke unit to you, does not mean that you can't get quality care or that you should immediately despair. Because I think about my neighbor, I think about my dad all those years ago. They didn't have mobile stroke units, but the medical systems are doing incredible work. And I'm just going to give the doctors a little bit of space because I don't want people feeling discouraged in any ways if they can't get this unit. Dr. Kelly, you want to start?
Sure. I think, as you just mentioned, we want people to call 911, if they have stroke symptoms. And, you may get evaluated on the mobile stroke unit, but we're very fortunate in Monroe County. We have 4 hospitals, all of whom have designations as stroke centers. So they can take care of stroke patients, very quickly. They're all prepared to take care and deliver early stroke care. Even as we get out into the Finger Lakes region, many of the hospitals there have primary stroke center designations. So the most important thing is just get to a hospital. Maybe the mobile stroke unit will be the hospital that comes to you effectively, but getting to a hospital and getting care is really the most fundamental issue.
Dr. Bala?
I would echo that. I think obviously it depends on the severity of the stroke as to which hospital can treat what kinds of things at any given time. But if you're having a stroke, the most important thing is recognition of those symptoms Dr. Kelly talked about, and then getting to your local emergency room as quickly as possible.
Josh, are you surprised at your age that this happened? I want to talk a little about what you think the cause was here, but are you surprised, first of all? I mean, you are a young man. You're my age, man. That's young.
It certainly wasn't something that I thought I'd have to, look out for. I haven't always taken the best care of myself. I probably didn't follow up with my primary as often as I should have. I guess in being a 20-year foreman construction worker, a lot of times if it's not bleeding, it's fine.
Yeah.
And not to say that that I was ignorant to taking care of myself, but I didn't have all the information I should have had. And also I think a lot of times, any time that I was sick or I thought I had an injury, if it didn't get better, it will. It wasn't a priority for me to run to the doctor and look for an excuse or look for an answer. It'll get better. This was not one of those. It was a perfect storm, and I got very lucky that I had access to something like the mobile stroke unit. I was lucky that I was in town. I was lucky that I wasn't by myself. And if I had been out on the golf course and it had been this time of year, may have been lying there. Somebody came up on me. I mean, I'm very fortunate, very blessed.
What you're describing with, if it's not bleeding, we're not going, that's the unfortunate condition of being a man. And often men do take more to actually go see a doctor. But also, I mean, the nature of your work is very physical, and you get used to sort of trying to downplay any bumps and bruises until probably something is really, really serious, right?
Yes, and to be honest with you, a lot of the work that I specifically do, we're isolated. We're up on the top of a building. We're not, we often don't have really immediate access to water or even a restroom, let alone medical care. You know what I mean? To the requirement that I would have needed. I mean, obviously we can handle first aid things, but I've been on jobs where somebody's had a medical emergency and it's you're getting taken down with a crane or you're getting picked up with a
Right.
a fire truck with a ladder. It's yeah, I just feel very fortunate.
So yours was caused by a clot, guys. That's right? His was caused by a clot. But what do we know what caused the clot for him?
It was just a kind of a irregularity with my heart. It would have slow moments, and then I had a clot building up in a pocket of one of my parts of my heart, and that clot eventually made its way through up to my brain.
Is that related to genetics and the lottery of like luck, or is that also lifestyle, diet, et cetera, guys?
I mean, it can be both.
Okay.
I mean, Josh, you're comfortable talking. I think,
In mine, it was both.
Yeah.
Okay.
I think, what we found is that there were portions of the heart muscle that weren't squeezing quite as effectively, and blood is not being pushed through that chamber of the heart as efficiently as it should. And if that happens and blood is pooling there for too long, it can form a blood clot, which can then break off and travel to any organ in the body. But we're most concerned about it happening in the brain. And the reasons for that, I think depend on the situations. There are genetic conditions that can contribute to that. There are lifestyle choices that can contribute. In many cases, it's some combination of both.
Have you made any changes in your life since the stroke?
Absolutely, yes. The medications I'm on definitely help with the just natural problems that I had, maybe the hereditary things.
Mm-hmm.
I mean, my mom's father passed away when she was 19 of an aneurysm at the sink shaving. So
Wow.
there's obviously there was medical history there that I wasn't maybe paying enough attention to, and absolute lifestyle. I smoked, for a portion of my life. I did, some of the improper things that drank a lot, and certain other things, and it didn't help. It definitely added up. It caught up. Let's put it that way. So the lifestyle changes are 100%. They were immediate. I don't think you get a bigger reality check than that.
Well, I appreciate the honesty there, and it sounds, again, you look great, you sound great.
Thank you.
I'm glad you're feeling good. I mean, this is a weird question, but do you wake up feeling like you had a stroke?
Not. No, I would say it happens more throughout my day when I just can't be as articulate as I want.
So it's memory or articulation of words?
absolutely.
Yeah.
I definitely don't spend as much time by myself as I used to. I have a lot of people helping me with that. And also it's just, staying on top of whatever is suggested by the physicians that I'm with, not pacifying it anymore.
So just briefly before I get to some emails, doctors, for people hearing not only Josh's story, but some of the definitions you're giving them about what's happening with stroke, is there a basic lifestyle set of recommendations? Is it simply, exercise, eat well? I mean, is that related or any more specific than that you'd want people to have?
I mean, I think there is a lot of that, but there are things we can't control despite doing all of those things.
Mm-hmm.
And stroke is one of those things that can come out of left field. It does have a penchant for the elderly, but again, like we said earlier, we see young patients all the time, and it's a combination of things we've inherited and combination of the choices we've made. Sometimes you can do all the right things, but things are out of your hand.
Doctor?
Yeah, I think it's never too early to start instituting healthy lifestyle habits, staying active physically, eating healthy. Those things, done in our 20s, 30s will pay off, with big dividends down the road. I think a couple of concerns. We are seeing strokes more commonly in younger people, even though it does skew towards an older population. And there are theories that maybe the typical risk factors like high blood pressure and diabetes that we used to, just attribute to older age, we are seeing at younger ages. And I would say if there is one medical condition that people can work with their primary care doctor on earlier, it's high blood pressure. That is something that is that is a can that is proverbially kicked down the road for a long time. And I would say, if that is developing in someone's 20s or 30s, it needs to be treated then.
Josh, did you have high blood pressure?
Absolutely.
Even before you knew?
Mhm.
Okay. All right. So,
Yeah.
so that's all right, consistent there. Mark emails to ask, is TIA a stroke? So we talked about ischemic and hemorrhagic stroke. TIA, transient ischemic attack. Mark wants to know, is it a stroke?
It is.
It's
It's a transient, meaning it's short-lived. Ischemic in the sense that there's probably a blood clot involved that's at the center of it. Attack means the brain is suffering. And the key there is that it's temporary, but it could be heralding a larger stroke to come, which is why all TIAs should be taken very, very seriously.
Okay. So, Mark, there's your answer. Now let me get a couple of other emails that are related to that. Sorry about this, guys. Email just kicked out on me here. There we go. So I don't know if this is related. Sean in Fairport says, I had a nasal MRI, and the doctor said that there was evidence of micro-ischemic damage. 2 doctors said this was not uncommon and nothing to worry about. I'm 67. Should I be concerned?
Well, I think this is a scenario we see quite a bit where someone gets a CAT scan or an MRI scan for another reason. And in doing that, we take some pictures of the brain itself and we, find things that may or may not warrant attention. Microvascular disease is a pretty common finding on an MRI scan. It's often attributed to the effects of things like high blood pressure or diabetes or smoking, things that preferentially affect these microscopic blood vessels in the brain. Again, it can be common in people, but I think a lot of it would depend on the actual extent of it in this individual. And so I think it's something that, might warrant attention from a primary care doctor, and at the very least, make sure that these things that we know are attributed to microvascular disease, like high blood pressure, smoking, et cetera, are being addressed.
I should have done my usual caveat when I have doctors here. It's really hard to diagnose patients over email, the phone, et cetera. And, they're giving you general ideas that they would give to anybody in general circumstances. So, Sean, I do appreciate the email, and it's a very good question. I mean, it's a very fair question to be concerned about. But, it sounds like talk to a primary if you want more information and kind of go from there. So,
Correct.
Al writes to say, just over a year ago while on vacation, my wife suddenly had no idea where we were, how we got there, etc. It was scary for both of us. Fortunately, she did still know who I was. We went to a rural hospital, and they did the tests that they were able to and pumped her with numerous IV fluids. After several hours, her mind cleared up. Followed up with a PCP and had more tests when we came home with no real diagnosis other than TIA. My question is, going forward, what can we do to keep her healthy if this was, in fact, a stroke? So before you get to Al's primary question, let me just ask up, listening to his story. Can you see enough, when you go to your PCP, if you've gone through what they've gone through, can they see enough to say that's definitely TIA or that's probably TIA? How do you know it was TIA after the fact?
Yeah, this is...
or do you know after the fact? Or can you only conjecture?
This is a tough one.
Yeah, this
Right.
is a tough one.
Okay.
So I think it's hard, especially after the fact, when we're not seeing a patient in the midst of their symptoms. It's hard to go back, even with really good history provided by a family member or someone else. It's hard to recreate exactly what's going on. By definition, as Dr. Bala mentioned, a TIA is a transient event and will not leave any kind of mark on an MRI scan. If it leaves some sort of mark or injury, it's no longer a TIA. It's actually a bona fide stroke at this point. So it's hard to prove that something was or wasn't a TIA. Sometimes, out of the proverbial abundance of caution, we will, especially if someone has risk factors or anything else that makes us more suspicious that someone's had a TIA, we may institute stroke prevention strategies. We might ask them to take an aspirin. We might have them focus on blood pressure, cholesterol, the types of things that we know, if left out of control, can contribute to more TIAs or strokes. But again, I think it would really depend on the context and the situation for that patient.
I think the key with TIAs is if, let's say, you are unfortunate enough to have one, the key is to get a complete workup, that there isn't a larger stroke down the pike that's going to come and harm you. I think what Dr. Kelly said is very important, is that a TIA does not leave a mark on the brain, but it can potentially signal that there is something going on that in the next few days you might have a larger event. So that workup is very, very important.
Yeah, I think it's not a perfect analogy, but I think what will maybe resonate with people is this is sort of like the equivalent of angina before someone has a heart attack. So someone is having symptoms that may be a precursor or, a warning for an impending heart attack. That's not to say everyone who has a TIA is going to go on to have a stroke. Most people, in fact, are not going to, but they are certainly at higher risk and should be evaluated accordingly.
Okay, let me get a few more questions in if we've got time. I think we do. Jillian says she says, I suffer from migraines. I understand a migraine is not a stroke, but I've been told that migraine with aura can cause stroke in the future. That's what Jillian is asking about. Doctors?
Yeah, migraine with aura is considered a risk factor for stroke. It's probably not to the extent of some of the more traditional risk factors that we have been familiar with for a long time, smoking and high blood pressure and things of that sort. But it is something that does seem to confer a risk. That's not to say that that it's likely to happen. The incremental risk is probably quite small, and so I would say patients, in that category, this is a situation where, again, if you are at slightly higher risk, let's control the things that we know are associated with a higher risk. So your blood pressure, your smoking, your lifestyle, those are things that we would want to address in everyone. But I would say someone with migraine who might have that slightly increased incremental risk, we want to be even more intensive about controlling in those situations.
Okay.
Yeah, I think this comes back to the earlier point that you were making, is that what leads to a stroke is really a combination of genetics and acquired risk factors. And there are things you can control and things you can't control. We can't do anything about our genetics, but we can do things about the choices we make.
Jillian, I'll also just tell you, as a migraine sufferer, I used to get 2 migraines a year, and they were big ones, aura, a lot of pain, dissociation. Now I get a lot of smaller ones, always aura, often no pain. I don't know why. It's been a long time since we talked migraine on this program, and maybe it's a good time to kind of call your colleagues over there and get an update on what we know about migraine, because still a lot of mysterious stuff with the brain. The brain's an amazing thing. Let's get one more here. This is Barb. She says, my husband and several members of extended family have had a stroke in the last 13 years. The day my husband had his stroke, I was not home. He called me and said, where are you? I told him, and he said, well, come home, but his voice was off. I asked, are you okay? And he just kept repeating, come home, come home. I immediately knew he was having a stroke. I kept him on the phone, and then on a separate phone, I called an ambulance to go to the house. They had him at the hospital within 25 minutes, and a CAT scan was done within 15 minutes. He could say yes and no, but not too much else. We pulled it up at the same time. He was sitting up on the gurney. I understand that you should not have a potential victim lie down. He was able to say yes and no to questions, but not much else. And we spent 3 weeks in the hospital, followed up by 6 weeks of inpatient therapy, followed up by 3 months of extensive outpatient therapy, and over the years, some continued therapy. I would say he's come back at about 75%. Therapy is very, very important, but someone who's had a stroke generally does not have the same cognitive or physical aptitude to do therapy on their own as maybe an athlete would. They need guidance and help and an advocate. So that's from Barb, a lot there. She mentions one thing that stands out to me real briefly here is she said she understood patients should not lie down. Is that correct?
Yeah. So
if you think you're having a stroke, don't lie down?
I don't think that they should lie down in the field. I think if we're going to have patients lie down, and there are benefits to patients lying down under controlled circumstances. What we're worried about in patients who are having stroke is their ability to swallow. Can they protect their airway? What we don't want them to do is we don't want them to aspirate and then have pneumonias and all those kinds of things that can compound the stroke on top of there. But I think that journey that was just described by
Barb, yep.
by Barb is actually quite acute, and it's quite telling, and it tells you how long that journey for that stroke patient and their families really is, which is why I think it's so important that the earlier we can make a difference, we can likely shorten that journey for that patient to recovery.
I hope that as we've gone throughout this hour, it's clear to the audience that time really, really matters. Josh has made that point. You might see him starring in a social media campaign making that point, very appropriately so. I'll give you about 30 seconds. Anything else you want to leave with the audience here?
I 100% agree with Dr. Bala. I was out of the hospital in 4 days. and I was back to work in a month and a half. So, time is of the essence. The other thing is, don't take for granted that we have all of this great medical coverage and that we have the people that know what they're doing. You need to be proactive. If you're going to live your life a certain way, then you need to stay on top of it even more so than somebody else. But the telltale signs, checking boxes, there's no reason to just be complacent about it. You need to stay on top of it.
You've done a great job this hour. It's been awesome having you because this story is so important, Josh. And I know it's not always easy to talk about, but here's to continued success for you and your family. And I know your daughter's going to be great. She's obviously already a very mature young person. So cheers to her and good luck to you, man. Thank you for being here.
Thank you.
Josh Graves, a stroke survivor. And our thanks to doctors Adam Kelly and Tarun Bala, talking to us not only about the UR Mobile Stroke Unit, but also what we all should know about stroke and care, prevention, and treatment. Doctors, thank you for your expertise. Great having you. Thank you very, very much.
Thanks for having us.
Thank you.
And I was going to sign us off here, but Rob, we should do another hour, shouldn't we? Yeah, we're on from 1 to 2. That's what we'll do. We're going to come right back with the Friday News Roundup next.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.